Okay, so we're here with Norman Doidge.
Hi.
Welcome. So you just published a new book. It's translated in French now, The Brain's Way of Healing. What is this book about?
My first book was called The Brain That Changes Itself, and it tried to establish that neuroplasticity, which is the power of the mind to shape the brain's structure and function, was real and clinically relevant and culturally relevant. And this next book is an attempt to unpack how neuroplastic healing works. It arose for several reasons. One of them was there were a number of brain conditions for which people were told nothing would help them and nothing was available. And with the new neuroplastic interventions coming along, I was suddenly in a position where someone would say, look, I've had a traumatic brain injury, or I've got a learning disorder, or my child has autism, or some such kind of problem. And there might be a number of neuroplastic approaches that would help that person. And I was trying to figure out how to determine what I would recommend. Mm-hmm. And so what I did is I tried to take this whole field of neuroplastic healing and break it down, see what made it possible, and I determined that there were actually different interventions were addressing different stages that got blocked in the body's normal healing process. Mm-hmm. For about several hundred years, people wouldn't use the terms brain and healing in the same sentence, mm-hmm. because it was understood that the brain was like a machine and it had parts or circuits, and if they broke, there was nothing that could be done to fix them, because machines don't. They don't grow, they don't change. Once we understood that you could use input into the brain sometimes to affect circuits, modify circuits, develop new circuits, and that the brain was plastic, there was a need now to understand, is there just one kind of neuroplastic healing, or do we address different levels? And I found that there are 5 different stages of neuroplastic healing. And so the book is organized by taking one kind of neuroplastic intervention, often applied to one kind of illness or several illnesses, that address each of the 5 stages.
Mm. And who do you address to which? For whom are you writing this book?
I'm writing it for anyone who wants to read it, by which I mean the following. It's both for the general lay reader, but it's also for professionals, and it's read by both. So it's taught in university courses, but it has a wide general readership. And the reason that is, by the way, it's funny your question arises, for whom did you write it? I think it arises because we're accustomed to expecting that scientific books are based on a very private, jargonistic language. Mm-hmm. And in fact, depending on the stage of that a science is at, that tends to be the case. Meaning, once a science is very well established, you usually have hyper-specialists writing just to each other in their own language, and they usually write in journals. But neuroplasticity is not just a new part of neuroplasticity research, is not only just a new exciting part of neuroscience research. Mm-hmm. These are findings which are requiring neuroscience to re-examine its core hypotheses as to what the brain is and how it works. And so in that sense, it's foundational. And it's often the case that the books that come along and address foundational topics are written in a very clear language.
Mm. What is this core hypothesis then?
Well, the core hypothesis, of course, is that the brain has a property of neuroplasticity, which means it can change its structure and its physical structure and its functioning in response to mental activity and experience. That's what neuroplasticity is. So plasticity exists at many different levels. It's at the molecular level, when certain genes are turned on to make proteins that'll allow neurons to connect with each other. It's at the level of in between departments in the brain. Sometimes whole hemispheres can affect the functioning of other hemispheres, and ultimately there is something called behavioral plasticity. all these changes together add up to effects on how our behavior can be modified or adapted or changed.
So which are the basic, you talked about illnesses or pathologies that you looked at, and which were the neuroplastic ways of looking at it or trying to heal it, as you talk about it?
Sure. So I'm not claiming that absolutely every brain disease or illness can be helped with neuroplasticity. We haven't looked at everything yet, and there are some which no doubt won't be helped. But there's the number of problems where we've seen people helped is actually very, very large. So I would say many, perhaps even most of the learning disorders can be helped, often very, very significantly. And some people who are born with devastating disorders can get over them completely. Others can be helped significantly. And learning disorders may be cognitive disorders, reading disorders, disorders in processing auditory input, processing symbols, disorders in logic and reasoning. And then related to that are sensory integration disorders, people who experience things that are too loud, too bright, and so on. This can be actually devastating. It can exist in babies who have colic or eating problems, often have sensory processing disorders that are leading to them to appear to have colic.
Yeah.
Certain children with autism can be significantly improved with neuroplasticity. So that's just one family.
Yeah.
At the other end, there are a number of people with traumatic brain injuries who can be helped. I write about how chronic pain often has a neuroplastic component. It's the brain getting too good at processing pain.
How does that work?
Well, one of the things we learned is that our sensory processing circuits can be trained. So a person can, of course, be trained in music and get better at listening to choral music and start to figure out the harmonies and the individual voices in the choir sometimes.
Yes.
They get more differentiation in their hearing. And that goes for all of the senses with training. They get better at firing faster, stronger signals, and the maps in the brain of the world of that sensory modality are much more detailed. But pain is a kind of sense too, and you can unfortunately get better at processing pain. And so if you have a nerve that's being constantly stimulated over and over and over again, what can happen is there are many pain maps in the brain, and the pain maps in the brain often map pain and do something else. So they're dual processors. For example, you may have noticed if you've ever been in pain for a long time, you can't concentrate well. Or you can't regulate your emotion. And that's because there's a part of the brain that both regulates emotion and processes pain. And the pain map literally expands in that dual processor to take over some of the real estate or the circuitry that processed emotional control. Okay? Now, when that happens, let's say, I write about a man who had an accident and he had a pain in the back of his neck that was a sharp, acute pain. Acute pain is not pathology. It's there to protect us from moving the damaged part. But he kept irritating the nerve, and after a while, if he moved a little, instead of it lasting a sharp second, it could last up to an hour or ultimately days. And he didn't just feel it in a point in his neck, but both sides of his neck, his head, and eventually his whole back. That is pain expanding in the pain map, which is getting, in quotes, better and better at processing pain. And that can give rise to some of the chronic pain syndromes. And knowing that, we can use neuroplastic techniques to wind that back so that it's just an acute pain. And often patients who suffer from chronic pain don't even have the acute pain anymore.
Yeah, and he did it in the book. You write some about Moskovich, who did it with visualization.
Yes.
Yes.
So, one of the things it's hard to do when you're in chronic pain is do higher math or geometry, and that's because there are actually several areas in the brain that process both pain and visual imagery. And he thought he could use the fact that brain plasticity is competitive, meaning if there's an area that'll process two different mental functions, it'll increasingly get devoted to the one that you do more of. So he was doing more pain processing, and if you were to have taken, a brain scan of that area at the time, it would have been more and more devoted to pain. So he thought, why can't I reverse that? What if every time I feel that pain, I force myself to visualize something? The second I feel the pain, as long as I feel the pain. And initially that meant visualizing much of the day. And he did this he was a pain specialist and a psychiatrist. And he'd read, thousands of articles on brain plasticity. And every time it happened, according to the principle that neurons that fire together wire together, he tried to strengthen his ability to visualize. And after many weeks of this, he noticed he actually had a pain-free period. Now, why is this important? Because he was a person who, by virtue of having been a doctor specialized in pain, had tried every medication, was on multiple medications. He tried nerve blocks, he had tried acupuncture, he had tried hypnosis, all the alternative things, and none of them covered him. Which isn't to say those things aren't valuable at times, because at times they're incredibly valuable. But in his case, none of them helped. And so here was a guy who was still on multiple medications, but they weren't helping him. And by the way, the reason they weren't helping him is because, and the reason so many people get hooked on these pain medications, is they were developed in a period of time when we didn't really appreciate that the brain is plastic. And so if you keep throwing a chemical at it, it just after a while says, boy, there's so much opiate around here.
Yeah.
I don't want to overreact to it, and it gets less sensitive to it. And then the doctor has to give you more opiate, or OxyContin, or whatever the drug is. And then the same thing happens. It says, boy, there's so much opiate around here, I don't have to make any, I don't even have to be sensitive to it, and it gets less sensitive. And the next thing you know is patients are on vast amounts of this medication, and they're addicted. And this is a huge, huge problem throughout the world now. We are addicting people to medicines that aren't even taking away their pain except for a very short period, and rendering them completely dependent on these things, because we hadn't appreciated that the brain is plastic, and there's this whole neuroplastic component to the experience of pain.
But you're writing about this specific case. What about if I would know somebody who's really in chronic pain most of the time? What would my advice be? What would your advice be? Is it just this one person, or can it be for everybody?
Well, let me distinguish. The short answer is it can be for everybody who has neuroplastically based chronic pain. So let me distinguish three kinds of pain.
Yeah.
There's acute pain that happens when you injure yourself, and it's important to be able to have that, as distressing as it is, because it's the brain's way of saying, don't move that body part. It's acutely injured, and there's nothing you can do about it. There's something that looks like chronic pain, but it's really acute pain, and that is, let's say, some of the pains of cancers that are growing in the body. They're eating into new areas, and each time they do that, they create a new acute pain. And then there's the kind of pain which is very, very common that's neuroplastically based. In acute pain, the body's injured. In neuroplastically based chronic pain, we might say that the body and the pain system both are injured. And what's happening there is, again, someone has got a nerve that's being stimulated over and over and over relentlessly to the point that the brain map for pain grows. And so this technique's been used for diabetic neuropathy. It's been used for certain kinds of back pains that were originally caused by an injury. It's actually been used for certain kinds of cancer pains that secondarily developed a neuroplastic component, many, many different kinds of pains. And I list all of those in my book. And so what it requires is a tremendous amount of perseverance and a reframing of how you approach pain. Many people, when they're in pain, try to adapt to it by tolerating it. Whatever the word tolerating means. It means both experiencing it and pushing through. This may look like that, but it's actually not. It's saying, okay, what brain areas might I engage to diminish my pain signal? And different people could try different things. The visual cortex, which, in other words, using visualization, which is what Moskowitz did, and I describe in the book exactly how he did it, is a good one, because most people can visualize almost anywhere at any time, even when they're lying in bed at night in pain.
And apparently it didn't matter what he visualized.
Weirdly enough, it didn't matter what he visualized. Well, look, let me put it this way. As far as we know, it didn't matter.
Yeah.
He chose to visualize something very interesting, because this had never been done before. So he chose to remind himself that the brain switches between states, and that, he got a picture in his mind of a real brain scan where the brain wasn't in pain and nothing was firing. Another one where it was in acute pain, and there were little sort of dots of these, about a dozen areas that are firing. And then a third brain scan of the brain in chronic pain, where it was like fireworks of firing in these dozen areas. And he just kept imagining it going from that to acute pain to not in pain. And he chose that particular visualization because he had to motivate himself. This had never been done before, and he wanted to motivate himself by reminding himself, the pain is just a brain state. I know that when you're in pain, you say, oh, my aching back. You don't say, oh, my brain. But in fact, look, we know, because we can use an anesthetic and block the signal, or we can turn off the brain and pain will go away, that the brain is very much a creator of the pain state. Or the brain and the nervous system together work to create the pain state. And they're actually gates that are like doors that open and close and let those signals pass into the brain. And people in the past had shown, yogis and various people with various experiments, that it's possible to get mental control to turn those off. But he wasn't just turning the gates open and closed. He was working on that brain map, that core brain map, to strengthen the ability to shift the gear up there in the central nervous system.
And shifting the gear up in that brain map, but another way of doing apparently is that shifting really to another part of the brain, like Parkinson, and apparently
right.
The man you talk about in your book just shifted the way he did a movement to another part of the brain. Do I get that right?
Yeah. So, people have tried various ways of classifying the different types of neuroplasticity. One form of plasticity is expansion, particularly in the sensory system, but not only, is we describe brain maps that map the world. And there are maps for the motor system, for movement, and if you were to put an electrode in a certain part of the brain, you might get an action coming out of the arm. And there's a whole map for that. We know that the maps aren't universal, they're modifiable, but they do tend to be similar from person to person. So we can fiddle with the maps to help people, but sometimes we can get completely different brain areas to take over functions in areas of the brain that are damaged. And that's the story I describe of John Pepper, who was a man who had Parkinson's disease. It doesn't just apply, of course, to John Pepper, it applies really to everyone with Parkinson's disease, I suspect, but certainly many, many people with Parkinson's disease. So this is a simplification, but this is the way people usually talk about Parkinson's disease. In Parkinson's disease, a part of the brain called in the basal ganglia has lost dopamine, which is a brain chemical, a neurotransmitter, that is necessary for the functioning of the basal ganglia. And the basal ganglia does many things, but two of the things it does that are relevant to Parkinson's is it knits together individual sequences of movements. It also knits together individual sequences of thought. So whenever you have a flow of movements that you do automatically, like brushing your teeth in the morning, remember when you first learned how to do that, you had to go down and up and then pull it forward and down and up and down and up and pull it forward, and you were conscious of each individual movement. At a certain point, probably for the sake of efficiency,
and survival, we learn to make those everyday routines automatic. And just even, dressing yourself in the morning and doing up a button, you don't have to think about that. In patients with Parkinson's, they lose that ability to do these automatic movements. Now they can, it turns out, do them if they focus their attention on each individual aspect of the movement each and every time. Imagine how laborious that is.
Breaking up in sequences
Yes.
of movement.
So, for instance, one of the sequences of automatic movement we do, where the basal ganglia plays a key role, it turns out, is walking. You swing your arms and you do that, and while you're walking, let's say you're a hunter-gatherer, you don't have to put a lot of mental energy into walking, so then you can focus on the animal that you're preying upon or that may be chasing you, whatever it is. So it allows you to divide attention, this automatic sequencing of emotion. And that's great. Now when you lose that, you're in big trouble. So patients with Parkinson's have a lot of trouble initiating new sequences of movements. So without going into how he figured this out, John Pepper figured out that if he paid attention to each individual walking movement, and I'm going to describe it in a very mechanically crude way, but just imagine that walking is kind of like falling forward a little bit, and you swing your right leg, imagine you're like a marionette puppet. Of course, walking's much smoother than this, as you well know. You swing your right leg forward at the hip, and then you tilt forward a bit more, and you land on the heel, and then you roll forward to your toe, and now you shift your weight to your right side so that you can raise your left leg forward at the hip, and so on and so forth. And in the meantime, you're also swinging your arms to counterbalance things. Well, he learned that if he focused on each of those individual movements, and I mean each one, he didn't say, I'm going to walk to the store, but I'm going to swing my right hand forward while I shift my weight to one side, and so on. He could actually walk. So that's the first part of it. And as he practiced that a lot, he got quite good at it. Now, patients with Parkinson's are caught in a noose, because part of the problem with that illness is our brains evolved to be part of moving bodies. It's not the reverse. It's not, as so many people speak about it as, we have these brains and our bodies are mere infrastructure for our brains. No. That is not only wrong, it's completely wrong. Evolution is such that animals had bodies, and then they developed brains and complex nervous systems to serve the bodies. And you have to think about the relationship between movement and learning to understand this. So when do animals, for instance, do a lot of moving? Often they're fleeing their environment because there's a predator, or they've run out of food and they have to go quickly because they're hungry. And what it turns out is when we do long walks, our brains trigger the development of new cells in our short-term memory system in anticipation of the fact that if we are going to a new environment, we are going to be doing a lot of exploring and learning. So a kind of neurogenesis within the hippocampus. Yes, that's neurogenesis in the hippocampus. But as important, and maybe even more important, the body triggers neurotrophic growth factors that help the brain, help it in two ways. Consolidate new connections, and also it supports the infrastructure in the brain, which are called glial cells. And these infrastructure cells also do process some communication. But they make up probably something like 80 to 85% of all of the cells inside our skulls. We often neglect them, but they're really, really important. And they also protect the brain and help to clear out waste products, etc. So they are so important for maintaining brain health. So once Pepper got walking, and he did it very, very slowly, he just started 10 minutes a day. And then every couple of weeks he added, I think about 5 minutes or so. And I go into the exact details of his protocols in the book. But really was just adding something every couple of weeks, because it's really hard to do this what he called conscious walking technique constantly. He got to the point where he can do an hour and 15 minutes or so. Every other day. Rest is really important, particularly for these patients.
Why?
Well, because in rest, we consolidate neuroplastic change. In rest, we do many, many things. You know, we reboot our immune systems, but we consolidate learning and we consolidate neuroplastic change. So you can really overdo this kind of exercise. So you have to be patient, and it would take him about 6 months to build up to doing this. And then he started to notice that not only could he move and walk, which in itself was a blessing, but that his other Parkinson's-related symptoms improved. Eventually, you know, patients with Parkinson's often have a kind of mask, which is they don't seem to express emotion on their face. And people noticed he was smiling. And he had many other disturbances, as most Parkinson's patients have. It's not just a movement problem. There are autonomic problems, and they went away.
Of his walking in itself? Or?
We think so, yes. And here's why we think so. We think so because, you know, well, first of all, in his case, he was actually able to go off his Parkinson's medication, which is remarkable. And I've, since writing this book, been contacted by other people who have used this technique or other kinds of exercise techniques to go off medications.
So he taught it to other people? Or?
He's taught it to other people, or people read my book and did it.
And figured it out.
And figured it out, because you can figure it out from my book. But several times, you know, life is complicated, and once he required surgery, and so he had a recuperative process, and he couldn't walk. And over about 6 weeks, he lost all of his gains, and he had to take that next 6 months to get back to where he was.
Oh, wow.
And then another time, as I recall, he had an infection, I think it was a pneumonia or something like that, where he was bound to bed. And from that, he again regressed. But when he started walking again, he got his gains back. So it was clearly, if you want to take that as an individual A-B experiment, seemed to be related very much to the walking. And because his Parkinson's symptoms, which were brain-based, regressed, it's our leading hypothesis is he was losing all the benefits of walking, which we now know include, of course, enhanced circulation, but also these brain growth factors.
You also talk about rewiring through light therapy.
Yeah.
How does that work?
Well, so light therapy, we've known that light can affect the body for millennia. You know, the Romans had light laws, and there were the ancient Egyptians knew that light was related somehow or other to growth, but also growth is related to healing. And so the ancients who didn't have access to medications, etc., often used light. And by the time you get to Florence Nightingale, she observed that light was very decisive for healing in the Crimean War. At one point, she had patients who were outdoors and others who were in a kind of army field hospital, and she was working with them, and she thought a combination of light and fresh air accounted for the fact that those who were outside were doing much better. Now in 1960, so there's, I mean, we all know deep down that light is related to growth and energy and so on. About 1960-61, lasers were discovered. Now lasers are really a kind of concentrated light. And there are really two classes of lasers. The original ones that got a lot of attention are lasers that destroy flesh. So these are certain specific frequencies that can be used, and they tend to give off heat, so they're called hot lasers. And they can be used in surgery, and in the movie Goldfinger, shortly after lasers were invented, Dr. Goldfinger says, "I too have a toy, Mr. Bond," and he ties Bond to, you know, with the spread, you know, his legs spread, and he's going to cut him in two. And that's how most people have heard about lasers. of our generation. But there is another kind of laser. Sometimes it's called cold laser. That's not a good term. It's just that it's not hot.
It's low frequency.
It's not the frequency. The frequencies could be in the 800s, for instance. But they don't give off. They basically don't give off. They don't give off heat. And it was observed that these lasers, when applied to wounds, healed them more quickly. When applied to animals that had wounds, they also noticed the hair around it started to grow. And this was used a lot in Eastern Europe and Russia, where they were more interested in the role of energy and healing, and they didn't have, multi-billion-dollar pharma industries to address a lot of problems. Started to really go with looking at the science behind low-intensity lasers. And they found that certain frequencies, when applied, for instance, to bacteria or even human cells, could lead to DNA replication. And they started to understand the sort of biochemistry of how they work. And we know that the mitochondria, which are the little powerhouses in the cell, actually kind of are triggered by either lasers or even LED lights of the right frequencies to re-energize. And people who are stuck in a chronic inflammatory process that's not getting better, and many of the autoimmune diseases are such. If you apply that light, they just move through to the end of the inflammatory cascade. So it undoes chronic inflammation. We now know that if you can grow cartilage with these lights. When I went to medical school, and still probably most doctors believe once osteoarthritis or rheumatoid arthritis destroys cartilage, there's nothing you can do to grow it back. But that's not true. We've got animal studies.
And that's proven.
Yes, we've got animal studies on that and human studies on that. I've helped personally just by referring people. Many people avoid knee operations or all sorts of surgical interventions because instead they were able to grow the cartilage back. It's brilliant on wound healing.
Is it widely used already, or is it?
It's not widely enough used. I mean, the overwhelming majority of people with these problems will be put on medication or go for surgery. And not only can it help rheumatoid arthritis and a range of illnesses that are autoimmune or inflammatory, it can even help osteoarthritis, which we talk about as though it's a rare wear and tear disease that just sort of scrapes down your cartilage, but people can be helped with that. And it can help. So people who are working on this, might, for instance, have a patient, and I describe such an example of a man who was in a car accident. And he'd also had a stroke. So he'd had a stroke that affected the back of his brain, the visual fields, and so his visual fields narrowed, so it was like he was looking out of a keyhole. He also had a car accident, and he had neck pain, so we went to his laser therapist, who I described. He put the low-intensity lights on the back there to help the neck, and the man observed, this is really strange, but my vision has gone from something like this to this while I've been doing the laser treatments. And boy, oh boy, that probably meant that this light, which was very close to his occipital lobe, was helping the occipital lobe do some healing. And then a woman named Anita Saltmarsh from Toronto had a similar situation. Someone had been in a car accident and she had a traumatic brain injury, but she got the lasers for her, I think it was for her terrible knees, which were terribly messed up in the car accident going forward. And the patient herself said, if this is helping heal my knees, could this help my brain? I'll sign anything if you would consider seeing if it would help my brain injury. And so they tried it, and it did help. And then in Israel, they've done a lot of animal studies of animals with traumatic brain injuries and with strokes. And they found that, those animals that immediately got the light right after the injury did much, much better. And in some cases, brilliantly well. I mean, shockingly well. if they got the light applied. So, you know, in my 5 stages of neuroplastic healing, which I use to try to, as a guide, to help myself and hopefully others determine which intervention to use, I try to address general cellular health in the brain first. And I believe one of the ways light works is by that. And the other thing that happens is the neuroplastic brain is a use it or lose it brain. So when it's injured or damaged, circuitry kind of goes into a dormant state or a latent state, and it's not firing as fast, it's not firing as much as it normally does. And you can use all sorts of things to turn that on. Every intervention I describe in this book is non-invasive, by which I mean there's no cutting, there's no surgery, there's no medication, which in a way is an invasive intervention, because if you take a molecule, you know, it goes through your bloodstream and it hits all this, you know, all the departments of the body, which is one of the reasons why we get side effects, because our magic bullets aren't perfectly, you know, they're more scattershot than we wish they were. So you can target this on the cellular health of the brain. They also probably stimulate some dormant circuits. So the 5 stages of neurohealing are address general cellular health in the brain, stimulate dormant circuits, modulate parts of the brain that are firing irregularly, which happens in many brain problems. I'll get back to that. The brain often goes into a relaxation phase after you do these things, where a person will sleep sometimes for 2 or 3 days, and it's very, very different from, it's not just catching up on sleep. They describe it as a deep restorative sleep that's unlike anything they've had in years. And that may be because people with brain problems are often sleep deprived. But even people who aren't necessarily that sleep deprived will often go through this phase. And the final phase is something I call Neuro Differentiation. And the work of Moshe Feldenkrais, or anyone who's working on brain maps and getting more detail into the brain, are doing Neuro Differentiation. But if I can just say a word, the neuromodulation. So one of the things that people, when I went to medical school, I was taught that if a person had a stroke and they lost 90% of the function of their right hand, that 90% of the motor cortex processors, the processors in the brain that process movement, are dead. That was sort of how we saw it. Most people still see it that way. And what I've learned by studying people who weren't supposed to get better, who got better, and by studying quantitative EEGs, which are basically records of the firing of thousands of neurons at once, is that's actually not often the case. You can have a 90% loss of function, but there may be many cells alive that you can recruit in the brain. And here's why. People often talk about brain cells as though they're on or off. In other words, they're either sending a spike or they're not. But actually, that's not right. The only time that brains don't send spikes is when brain cells don't send spikes is when they're dead, okay? What they're usually doing is they have a basal firing rate, which is sort of means I'm not that active now, and then a faster rate, which means I'm active now. This is a spike. Sometimes it's reversed. Sometimes the basal rate is fast and the active rate is slow. That's true. But the point is the brain is, the cells are always firing.
So maybe they can get out of sync then.
But they get out of sync, that's right. So when there's damage, some cells die, they don't fire anything. Some cells are sick. They may be not getting proper supplies of oxygen, or there may be some kind of cell injury, and they are firing at an aberrant or an incorrect rate. And then they send that junk data to the healthy cells who are getting input that they can't quite use. And so what you have is some sick cells aren't working, the healthy cells aren't working, and most of them are healthy probably. And then maybe there are some healthy cells that aren't getting junk data. And so what we've learned is if you can resynchronize the firing of these sick cells, or at least quiet them down so they're not interfering with the healthy cells, you can suddenly get quick improvements. And there are many ways we can do that. And it seems that light is one of the ways we can do it. Sound's another way.
Yes, sound seems to like resynchronizing through sound.
Yes.
Through the ear.
Yes.
Through the hearing. Through the...
So one of the things that, you know, there are books now like This Is Your Brain on Music and books about why music is so powerful in the brain. And one of the things about music is it turns on many, many parts of the brain. It doesn't just turn on this huge sound cortex, if you will. You know, if the music is right, you want to get up and dance or move, or it can lift your mood. And it does affect the mood centers, and it does affect the motor centers. And if
How?
It's, we just seem wired that way. I mean, we've evolved in such a way that one of the ways we can pay attention to the world and is through our ears. And so sound can wake us up in the morning. It can say, sleeping brain, awaken. So the sound goes through the ear. It seems to affect what's called the reticular activating system, and it affects our level of arousal. That's really important. And it can energize us like a battery to the brain. It prepares us for action once we're awake. What are we going to do with that? Because of language, it's tied into the centers of abstraction and meaning and mood. So think about it.
It can heal.
Yeah, and understood properly, it can heal. So, I mean, just to give one example, let's go to a very challenging situation. A lot of kids with learning disorders have sound sensitivities. This is something, when I did my training in medicine and psychiatry, it was just like one tiny little symptom in a long list of things that might affect kids with learning disorders. It's actually huge, because people who are hypersensitive to sound, and it's taken me years to really assimilate this. If someone was to burst into this room, or if an alarm would go off, we would be completely focused on it, and we'd immediately go into fight or flight, and we'd become hypervigilant, and we'd turn off other systems. We'd actually turn off our social engagement system. You wouldn't be attending to me, you would be attending to that sound. So imagine there were people who are hypersensitive to sound. It's like their world is a world of constant alarms. Now, children with autism, most of them are hypersensitive to sound. Not all, but most. And many kids with learning disorders, auditory processing disorders, sensory integration disorders, which is, as a family of people, are hypersensitive to sound. And what's going on in them? Well, that was figured out not very far from here, around Parc Monceau in Paris by Dr. Alfred Tomatis, 50 or more years ago. He figured out that the ear has within it the equivalent of a zoom lens, like you have in a camera. But instead of focusing close or far, it focuses on certain frequencies. So when you go into a party or you go to a bar, at first you hear booming, buzzing, confusion, and a rumble. You can't really make out anything. And as time passes, you can begin to focus in and eavesdrop, if you're like so inclined, on a particular conversation by some mysterious form of concentration that you do, which is your zoom lens finding that frequency of human speech that attaches to that conversation. It's just a wonderful, wonderful thing. And imagine you're an animal in a forest, and there are the rustling leaves and the babbling brook and little creatures that you're not afraid of scuttling around, and then there's a low rumble of something that could eat you alive. You want to be able to focus where you have to focus. But these kids, let's stick with a number of kids with autism, they don't have that working. So they are in a constant fight or flight reaction. Now, the fight or flight reaction is called the reaction of the sympathetic nervous system, and it prepares you to run or to fight, as everybody pretty much knows. And there's another system that can turn that off. That's the parasympathetic system. And most people in the healthcare professions know that the parasympathetic system is calming, and it turns off the fight or flight system, and many people know that it's also related to growth and healing, especially healing. So that's a very good thing, which is why we want to be calm when we're getting a treatment if we can. Something a lot of our hospitals don't know about. But the parasympathetic system is involved in another series of activities that are all related. And that is they turn on something that's called the social engagement system. So the social engagement system is a family of brain circuits, most of which are experienced through the human face, that allow us to do the following. They allow us to focus in on the frequency of human speech. They allow us to articulate human speech. They affect facial expressiveness. And so all of these are wired into the brain through what are called the cranial nerves that go into the brainstem. And, autistic kids have problems with this whole system. So they often will, for various reasons, they often will avoid another person's gaze. They find it overstimulating, but they find it overstimulating because they can't regulate that social engagement system and the input. Sometimes their faces have a particular sort of flatness about them. Again, these are facial nerves. Sometimes their voices are kind of monotone or almost metallic. And that's related to these cranial nerves in the social engagement system. So to give a long answer to a short question, Tomatis learned how to train the ear to develop the auditory zoom properly. And it's complicated, but basically he learned to take music and modify it. And he did it by the individual. Now there are programs out there where people sort of send away for some equipment and are expected to do it on their own. I think you really should work with a clinician. The way Tomatis did it individually, and he had analog complex equipment, and he was able to train people. And I write in detail about Paul Medall, who is a student of Tomatis, who's now in Canada, who I think does it up to the standards of the original and the way they're done. But basically, what you see with a patient for whom this is the appropriate intervention is nothing less than extraordinary, and I describe these cases in my book. So I believe autism is not simply a brain disease, as everyone thinks about it these days or talks about it, but it's a whole body disease that also affects the brain, which means that the interventions to help autism have to address not just the brain, which is what I'm focused on, but other things as well. Sometimes that means diet and things that are triggering inflammation, which is very, very prominent in autistic kids. But assuming you're addressing some of these things, the children who get this intervention might, within 2 or 3 days of starting this, stop covering their ears all the time and look up to their mom and hug her for the first time and look at her back and forth for the first time. And, if you don't know anything about the science, you'd say, well, that's miraculous, or that's impossible because it doesn't fit my paradigm. But if you understand that the social engagement system is something that exists in us, and it exists in autistic children, it's just turned off. By turning off that constant fight-flight system, the social engagement thing turns on. And so it's not surprising that all the elements of the social engagement system, once it's turned on, would be working. The eyes are working, their speech can start to improve, their sense of affection can ramp up quite quickly, and the distress from hearing is diminished.
So you mentioned him earlier, but you said that one of the first persons who understood that the brain is plastic is Moshe Feldenkrais.
Yeah.
How did you get to that? And did you experience it? And
I actually was fortunate enough to have sort of a problem with my neck and back from years and years of sitting in chairs and writing and studying and so on. And so I was looking around for help for that. And one of the things some person who also had problems recommended was Feldenkrais work. So I went to visit a Feldenkrais practitioner in Toronto named Marion Harris, lovely, lovely woman, and she gave classes in individual sessions that are called functional integration sessions. And I did that for a number of years and started reading Feldenkrais's work. This was in the mid-90s. And I realized, I mean, he was just an incredibly powerful, integrative thinker. But because he worked with the body, like many people who work with the body, it's often very hard to describe what you're doing with the body. We don't have, all that sophisticated language for describing, the subtle forms of kinesthetic sensation and why you move, what, where, when. But over the years, I integrated his approach. Like, I saw how his approach was basically a way of moving the body or getting people to become very sensitive to what it was like to move, that it involved refining brain maps. I basically also saw that he was using movement to talk to the brain. He wasn't trying to knead muscles to get blood flowing there, which is sometimes a good thing to do.
Mm-hmm.
I get that. But rather, he would use these very delicate movements that the patient would never understand necessarily why he's doing what he was doing. I guess I was very taken by the fact I really couldn't understand why Marion would be moving things the way she was moving them. And yet it was having an impact on my entire nervous system, and his understanding was holistic. So it took a number of years, I would say, to find a place within plasticity as to where I saw Feldenkrais fit. And there are many different interventions that I could have perhaps described in that chapter, where I was trying to describe how we can give our maps more detail or differentiation. But because Feldenkrais understood that he was aiming towards differentiation, I chose him, and he's he's a deep thinker about these things. I could have done it on Tai Chi, which in some ways also is very much about learning to differentiate movement. But Feldenkrais read a lot of neuroscience, and he was exposed to the work of one of the people who was one of my heroes, Dr. Paul Bach-y-Rita.
Mm-hmm.
And in fact, Paul Bach-y-Rita's wife
was a Feldenkrais practitioner.
Yeah, was a Feldenkrais practitioner.
Mm-hmm.
I believe her first name is Eileen,
Mm-hmm.
not Elaine. And she thought, my goodness, wouldn't it be great if Paul, who was really one of the 2 or 3 major pioneers in neuroplasticity in the 60s and 70s. There really were just a handful of people.
Mm-hmm.
If Paul met with Moshe, and initially Paul was pretty skeptical, but he got more and more interested. And unfortunately, he passed away before he could do some of the studies of Feldenkrais work that he had actually intended to do.
Mm.
But Feldenkrais, now through Bach-y-Rita, had a language of plasticity which he used from time to time to explain what he was doing. But very early in his work, he said he understood that the difference between human beings and other animals is we have this premature birth, if you will. In other words, some animals are born and they can get up and walk and to some degree fend for themselves, and human beings are completely helpless for the first, not just 2 years, these days perhaps 2 decades, but from the point of view of being undeveloped, unprogrammed. We have some things that are programmed, but our nervous systems are remarkably unprogrammed compared to some other animals. And this is something Freud pointed out. He was very, very big, and many people were big on what was sometimes called the premature birth of human beings. And that's because our brains are so big and become so big, and that's our survival advantage. But the human pelvis, the human female pelvis, can only be so big. And so there's a kind of race between how much we can grow and how big the pelvis can grow. So we're born, quote, prematurely, and then we are dependent upon our parents or the environment for giving us exposure to teach us the skills that we will need in life. I mean, really, really basic skills that we'll use for the rest of our lives. And what that also means, because we are so, I hate to use this computer language because I reject the computer metaphor, but that's what Feldenkrais used in that passage. Because we're so programmable, we're also really prone to learning things that are not helpful. We're prone to bad habits. And because of that, because the brain is plastic, plasticity is neither good nor bad. It is what it is. It can go in positive or negative directions. It's very, very helpful to understand the principles of plasticity, because sometimes you want to undermine habits that you've developed which are no longer helpful.
And what drives you actually, to keep on writing about the brain that changes itself, the brain's way of healing? What drives you in that?
That's actually like a very, very broad question. I'll give a more experienced near answer, which is not totally satisfactory. But a long time ago, I just learned that I would do my best work if I followed my interest. So I don't drive the process. I'm a good slave. I follow my interest, and this got me interested. A number of years ago, I interviewed Saul Bellow, who was one of my favorite novelists, and I asked him why he put some parrots at the end of a book he wrote. These parrots descend on a scene in Chicago, feral parrots. And he said, I don't think there's any great symbolism there. He said, I was in a conversation, there were parrots. It interested me. I figured it would interest other people. So, that may sound glib, but it is incredibly interesting. And but it also helps, I would say, even, before I was a medical student, I was a philosophy student. And had life gone differently, I might have become a philosophy professor. And as I started to study the rise of modern medicine, I was also interested in poetry, and still am. And that allowed me to smell a metaphor. I like metaphors, but I can also smell metaphors. And when people started talking about the human being as a machine, and the brain is a machine, it seemed, very scientific. It seemed like people who used those metaphors felt they were even more scientific by saying that. And yet it's very odd that we would talk about this animate thing which grows and changes and has consciousness as a machine which is completely inanimate and doesn't have consciousness. So there was a sense of that discomfort. And I'd read enough philosophy to sense that the ancients didn't see it this way. Their words were more open, were less committed. Now, part of the reason is ancient machines were not as impressive as modern machines. Ancients were impressed by human beings. They were impressed by the starry heavens above and by animals. Aristotle and others would talk about organisms. There was a sense of organization, order, form, but they didn't say machine. With the rise of modernity, Descartes talks about the brain as a kind of hydraulic machine. Always some discomfort about that, shift into that metaphor. But what did I know? I hadn't studied medicine. I certainly hadn't mastered my field in medicine, which would eventually be psychiatry. So I was an observer, willing to learn. And then what happened was in the 1990s, with the rise of genetics, this machine metaphor got attached to genetics. And if patients had depression or some kind of learning problem or whatever it was, my colleagues would often say, and they didn't get better, my colleagues would say, oh God, this guy's depression is hardwired in. And that was a shorthand for, they were an electrical machine with wiring that couldn't be changed, and it was genetically predetermined and genetically hardwired, whatever that metaphor. So they had a double-barreled metaphor, which basically sealed their fate and led to this kind of neurologic nihilism. Now, I also observed that when patients with very similar conditions got better, that they never used this metaphor. They said, boy, isn't our medication great? Thank God for this medication, or thank God for my psychotherapy, or whatever. And it became pretty clear that this was a very opportunistic metaphor and being used without a lot of thought. And then I knew from my studies of psychoanalysis that development is a very, very powerful model that was neglected by the metaphor. I mean, once you say a person's a machine and yet you see that it's developing and changing capacities all the time, how do you marry those two thoughts? It's not so easy. And I saw how strained it was. And even Freud at times seemed a little caught between the two. I mean, and that is in part because he received that metaphor from his teachers and was a good and loyal student, you know, and so he talked about the psychic apparatus, although in German it's actually almost funnier because he calls it the psychic contraption. It's more like contraption. And he talked about defense mechanisms, but that was justified because they are kind of automatic because they're unconscious. But there was a little bit of the hydraulic metaphor from time to time. But the main thrust of Freud's work, his original ideas, were always pushing against the machine-like model of his teachers. And so, you know, he was very Darwinian, and he was into growth and development and so on. So I knew from that side that there were problems with it. And then finally, I knew from the experimental literature, you know, by the empirical literature, by people like Kendall, etc., that it just wasn't true that these connections stay in place. So, you know, by all of these, whatever you want to call them, following my interest, with my interest as my guide, or accidents of exposure, all these things were lining up to say, you know, this model really is wrong. And that neuroplasticity is not just a new interesting area within neuroscience. It actually has revolutionary implications that require that we completely re-examine our model of the brain. And that's why I wrote the first book, to try to make that case. And I think that right now the situation is such that there are people within neuroscience who think of it as an interesting area, and more philosophically or holistically or systemic thinkers who realize that actually it's not just a new area. It's something that calls into question a number of the fundamental hypotheses that are working assumptions in clinical psychiatry, clinical psychology, clinical neurology, and the healthcare disciplines.
You've written 2 pretty revolutionary books. What's your next one going to be?
Well, actually, my next one is a novel, which I put aside to work on these 2, because, again, I followed my interest in the, you know, it seemed to me certain things were coming together. And I'm well into that novel, and I hope to